Good morning. I think it's the time to start. So let's start. So today we are now entering the musculoskeletal system, and in musculoskeletal system, the muscular and neuromuscular or paralytic disorders are an important part any physiotherapist is going to come across. So out of this, the cerebral palsy is very commonly seen. So it is a persistent but not changing disorder of movement, tone, and posture resulting from a non-progressive defect or lesion of immature brain. So these are the four characteristic features we have to remember, that this is persistent disorder of movement, tone, and posture. The primary defect is a non-progressive lesion in immature brain. It can be prenatal, perinatal, and postnatal. Commonly associated with the spectrum of developmental disabilities such as mental retardation, epilepsy, visual hearing, strabismus means visual problem, cognitive dysfunction, sensory problems, emotional and behavioral problems. So any part of the brain or the brain can be affected on the whole. There could be overall mental retardation, there could be recurrent CNS stimulation leading to epilepsy. One can have visual, hearing, and speech problems. Then there is a squint and uncontrolled movements of the eyes called strabismus, cognitive dysfunction, which is called wisdom, and then sensory problems, emotional and behavioral problems. You must be excluding progressive pathology. If it is a progressive pathology, it is not cerebral palsy. Non-progressive genetic or cognitive form information are overlapping. William John Little first time described it, so it was called Little's disease. He said that motor deformity resulting from difficulties in the birth process. He was an orthopedic surgeon who developed that children with tone and developmental abnormalities often had prolonged labor, prematurity, or breech delivery. Classification: we can classify cerebral palsy on the basis of topography and on the basis of physiology. Topographically, which part of the brain is involved? So the problem can be monoplegic, hemiplegic, diplegic, quadriplegic, double hemiplegia, and triplegia. The physiological classification: whether the muscle deficit is spastic, if it is extrapyramidal, ataxic, related to gait, mixed, atonic. So this is the anatomical classification, which means quadriplegia, all the four limbs are involved; diplegia, both the lower or upper limb are involved; hemiplegia, one upper and one lower limb; triplegia, two upper and one lower limb, or two lower and one upper limb; monoplegia, single limb; and then there is pentaplegia, in which the trunk is also involved. The functional classification: class 1 having no limitation of activity, class 2 slight limitation, but the still child can carry out major activities and self-care, and class 3 moderate limitation, patient is unable to have the independent ambulation, class 4 patient is wheelchair bound. Gross motor function classification system for assessing severity of cerebral palsy. So these are the different levels. Level 1 are normal, level 2 walk without restriction, limitation, but there are slight changes. Level 2 without assistive devices. Level 3 walks with assistive mobility devices. Level 4 self mobility and limitation is there. Level 5 self mobility is severely affected. So the site of brain injury dictates the what pathology will be seen. The cortical, there is a periventricular leukomalacia, subcortical. This leads into spastic diplegia, periventricular hemiplegia, basal ganglion, and then there is involvement of cerebellum, brainstem. If the cerebellum is involved, this leads to cerebellar ataxia. Basal ganglia or brainstem involved, this leads to dyskinetic type of epilepsy. So these are the neuropathology: hypoxic ischemic brain injury, parasagittal brain injury, periventricular leukomalacia, focal multifocal ischemic injury, status mammoratus, and selective neuronal necrosis. Hypoxia, बड़ा word use कर रहे हैं हम. Hypoxia means diminished oxygen supply to the tissue. Ischemia, diminished blood flow to the tissue. Asphyxia, disturbance of gas exchange in fetal maternal circulation result in increased PCO2 and increased oxygen concentration. So intrapartum asphyxia, loss of normal cerebrovascular autoregulation flow, decreased perfusion of the brain, and further reperfusion injury, and interventricular hypoxia. So these are the different brain areas. So severity, motor development, motor age divided by chronological age into 100. If the score is more than 70, minimal. 50 to 70, mild motor disorder. Less than 50, classical CP. And motor age, you check certain reflexes which are present in neonatal life, and then you see the motor skills. So this is the etiological classification. The CP can be prenatal, iron deficiency, UTI of the mother, chorioamniotosis, hypertension, uncontrolled diabetes, tetrogens, drugs, poor antenatal care, low C-section, twins, fetal vasculopathy. Perinatal, which are around the birth asphyxia, most common cause. Prematurity. There could be intrauterine growth retardation, hyperbilirubinemia. Then there could be interventricular septal defects, sepsis, pneumonia, developmental malformation, postnasal, CNS infections, head injuries, seizures, hypoxic damage, hyperpyrexia, and then their damage. Cause of most CP is unknown. Most children with CP did not sustain intrapartum asphyxia. However, intrapartum asphyxia does occur and is an important mechanism. At times, it is unidentifiable. Early markers of CP: slow head growth, poor head control, roving eyes, poor hand, persistent squint, ear, lack of auditory response, irritability, seizures, poor suck, poor quality of sleep, extreme sensitivity to light, cortical thumb beyond 8 weeks, headedness before 2 years, paucity of limb movements, scissoring of lower limbs, toe walking, abnormal toe, persistence of primitive reflexes or failure to acquire posterior reflex. This is very important. The child has certain primitive reflexes. They go by certain time. A few of them disappear by 6 months, majority by 1 to 2 years. And if they are present, that means the brain is immature. Then stereotypical abnormal movements, lack of alertness. These are the primitive reflexes. This is the normal reflex. If you hold the child free, prone, the child acquires flex position of the elbow, flex position of the knees, and flex position of the hip. But in CP, it will be floppy. जैसे कुछ चीज अकड़ जाती है. Extended limbs, all the limbs. Similarly, if you try to sit the child, so that will curl all the limbs, for upper limb and neck. Body stiffness like a board. Child will be unable to play with the toys. So these are the different reflexes. Ataxia. If you ask the child to pinpoint, उसे कहें कि ये रैबिट या टॉय है, इसके नाक पे हाथ लगाओ, तो that child will be unable to. That is called ataxia. The diagnosis of cerebral palsy is first initial complaint is to failure to meet early developmental milestone. Delayed milestone is the first symptom. No evidence of progressive disease. Disease is not progressive. The disability may be progressive. No loss of milestone acquired previously. Delayed milestone, persistence of primitive reflexes, pathological reflexes, and failure to develop protective reflexes. How do you evaluate? First, assign the etiology, whether it is prenatal, postnatal, perinatal. Then exclusion of other plausible explanation, congenital brain anomalies, genetic and dysmorphic syndrome, congenital infections, inborn error of metabolism, postnasal anoxic infectious and traumatic lesions. Spastic diplegia involve legs more than arms, often associated with premature birth. Only 11 to 20% are severely impaired. Motor response is not profound, and 10 to 33% of all the CP they have spastic diplegia. The child will be having spasm, and both the upper or lower limb will be involved. In the lower limb, it results in scissoring gait. This is diplegia, spastic diplegia. The upper limbs are normal, contractures of the hip, knee, and feet. So, spastic quadriplegia, then both the upper limb and both the lower limb will be involved. The lower limb there will be scissoring, and the upper limb there will be fisting. The child will be holding the fists all the time. Hemiplegia, involvement of arm and leg on the same side. One side motor handicapness, intelligence is normal or dull. It is also 1/4 of the cerebral palsy. You can see the one limb and upper and lower limb is okay. The right side upper and lower limb is spastic. Extrapyramidal CP, defects of posture and involuntary movements, athetosis, dystonia, ataxia, and hypertonus. There is a difference between spasticity and rigidity. Spasticity is a continuous process of increased muscle tone, while rigidity, it is a pathological stiffness of the muscle. Differential diagnosis, it is especially confusing in hypotonic phase with the diseases like myopathies. Neurodegenerative conditions can mimic CP. Dopa responsive dystonia and organic aciduria like glutaric aciduria may look like dystonic CP. You must assess the child regarding growth, nutritional disorders. These kind of children have frequent respiratory tract infections because of the reflux and ineffective cough reflex. Facial dysmorphism, skin should be inspected for neurocutaneous stigmata. Head circumference should be noted and plotted. Reliable measures of length may be difficult to obtain due to concomitant contracture of scoliosis. Alternative measures to the growth such as length, skin fold thickness. Neurological evaluation, you must check the developmental milestones if they are delayed or not, and then motor, sensory, and gross skills of the child. You must assess the cranial nerve, the posture of the child, muscle tone of extremity of the trunk and neck, deep tendon reflexes, postural response, and primitive reflexes. Physical examination should include the child in prone, supine, sitting, standing, and if appropriate in walking and climbing positions. Then you must follow the assessment in current level of functioning, such as is the child is unable to carry on daily activities, feeding, dressing, brushing, self-care, and what adaptive changes the child has done. Disorder in movement and posture, then postural reactions. Must assess the muscle tone. If it is increased, if it is called hypertonia and spasm. And if the muscle is otherwise stiff pathologically, the tone is normal, then it is called rigidity. Mental retardation by checking the common sense and wisdom of the child, conventional tests for intelligence, checking of the IQ level, they are very helpful. Age appropriate non-verbal intelligence test. For example, the child is able to pick up an object. Ask the child, go and bring your toy. If the child is unable to understand, that means there are cognitive behavioral problems. The hearing problems are very common, especially CP resulting from torch, which is a toxoplasmosis, and different viral infections resulting in impairment of blood supply to the premature brain. One must see the speech and language ability of the child, feeding and nutrition, tongue thrust or tonic bite, hypersensitivity to touch, drooling of the saliva, and dental hygiene must be assessed. Orthopedic problem may be hip subluxation, scoliosis, equinus deformity, contractures of hamstring muscles, and tendo-Achilles. Reduced bone density and propensity to fracture. Equinus is the most common deformity. Then followed by knee and hip flexion contractures, scissoring or adduction contractures, elbow is flexed, pronated, the fist is closed. Epilepsy is most commonly associated with CP or results from CP. The child will be having recurrent fits. Neuroimaging, MRI and CT to see the intracranial defects and congenital anomalies. So disabling conditioning should be evaluated. Pathophysiology of the disease should be understood. Impairment of the patient clinically should be assessed. Functional limitation from this impairment should be checked, and overall disability, which is the effect on daily living, should be evaluated. And then societal limitations, which are social limitations. You must assess the home situation, whether the parents and the child are able to cope up with the deficient child rearing conditions. You must facilitate. On the other hand, poverty, illiteracy in parents, large family size, frequent change in residence, non-availability of special rehabilitation centers may deprive the child of appropriate care. You must see the hemiplegic type CP has the best prognosis. Age of sitting is good guide to prognosis. If the child is early to sit, around 2 years, the patient can walk. If the child is unable to sit by 2 years, he will hardly be able to sit and walk. Pediatrician initial role consists of making a correct diagnosis, identification of the type, extent and severity of the neuromuscular disorders. How? This is very important. How do you disclose it to the family? Breaking the news. It should be multidisciplinary, multi-sessions, sensitize the children and parents. It should be involving the physiotherapist, occupational therapist, clinical psychologist, speech pathologist, orthopedic surgeon, otolaryngologist, ophthalmologist, teacher, play therapist, social worker. Physiotherapist has a special role. If physiotherapy is established and is offered to the family early in the life, it is helpful in promoting normal motor development and preventing deformity and contractures. You must be aiming at reducing abnormal pattern of movement and posture, preventing contractures, promoting functional capabilities, and number of techniques are there. Guiding the child and family, inhibition of primitive and abnormal reflexes, reinforcement of normal posture reflexes, facilitation of normal movements. This is how you can help the child to walk by a frame. You can ask the child by a trolley to crawl. Then there should be role of occupational therapist, physiotherapist and occupational therapist. They help each other. You should try to promote the child to feed him or herself, and horse riding is very good. You can give them the horse riding toys. Play therapy. The child is promoted to go to play, and this is how the child has the ability to develop, to learn, and to improve. Certain tasks are given, such as ask the grandparents must ask for the child to do something. Masalan, fetching a glass of water, bring small objects, clean up your room, wash your clothes. You should promote sitting. By this, you must promote lying prone, must try crawling and standing. These are the different things where the child can be helped. You can see how it can be used. Assistive and adaptive devices, various simple modifications like angled spoons, angled cups, they can be offered to make the child helpful. Old stools and boxes can be adopted to provide support during sitting. Parallel bars, sorry, I had to attend a call. So we continue assistive and adaptive devices. Simple modification at home. Stools, boxes, the play area, parallel bars, standing frames, prone boards, the way I have shown, are very helpful. Sitting. If the child is unable to sit himself, especially in pentaplegia, then you can have the modification. You can see the arm holder, the neck holder, the auxiliary support, then the uh, feed positioner. They all are different paddings which can help the child to sit straight. A number of high technology vehicles and devices like programmed wheelchairs, electronic feeding devices, various systems, computerized speech systems, cochlear implants now are available which help the child. Then, as a physiotherapist, you must be able to apply splints, casts, calipers. You can refer for these to an orthopedic surgeon. Specially designed shoes, AFOs, and calipers. They help the child to go for normal or near normal activity. AFOs are particularly useful in children with spastic diplegia who have dynamic spasticity with tendoachilles tightening. Management of spasticity. This can be done by medicines. Baclofen is the drug of choice. It enhances the GABA activity, and GABAs are the inhibitory pathways in our central nervous system. As the function of the upper motor neuron is impaired by ischemia, the lower motor neurons, they are excitatory, and the inhibitory role of the upper motor is gone. So giving them baclofen, which is a GABA activity modulator, you give an inhibitory role or a shut up call to the lower motor neurons which are firing continuously. It can be given into 1.25 to 2.5 milligram BD orally and is increased up to 30 milligram per day. Diazepam, which is a small dose given half an hour before physiotherapy, it is very good muscle relaxant. But the dose should be very low as it is also sedative, hypnotic, and Overdosing can lead to respiratory depression. Peripheral muscle relaxant as anidine, which is 2-adrenergic agent, and dantrolene sodium, which acts on the calcium channels, have been used with limited experience. Baclofen intrathecally has shown very promising results. There are implantable infusion pumps which may be helpful in cases of severe spasticity or disabling totally dystonia. Botulinum toxin into the muscle substance. Botulinum toxin that is actually paralytic to the muscles. So this leads to temporary paralysis of the muscles which are spastic actually. It is given intramuscular. It is produced from Clostridium botulinum and it acts by blocking the release of acetylcholinesterase, which leads to loss of motor end plates. As affected nerve roots sprout from new injections, relaxing effects reverse over 3 to 6 months. It is more often used in children with spastic diplegia. Surgery is useful in some children with spasticity, especially where mainly the lower limbs are involved. You can facilitate by tendon lengthening, and generally you should do as maximum surgeries as possible, but you should have a balance of not overdoing. So cerebral palsy, you can have the surgery such as dorsal rhizotomy, in which the posterior nerve roots of the spinal nerves are cut, because for this to understand you must undergo the tendon muscle reflex pathway. The muscles are stretched and then the receptor pathway goes to the spinal cord, and spinal cord again gives orders for the muscles to act. If you go and cut the dorsal rhizotomies, posterior roots of the nerve roots, spinal nerve roots, this results muscle relaxation. Then you must address the athetosis and dystonia. Surgical procedures are tenotomies, tendon lengthenings, release of contractures, tendon transfers, capsulotomies, tenodesis, fasciectomies, osteotomies, arthrodesis. Now I'll let you know one by one. Tenotomy, in which you go and percutaneous or openly cut the tendons. If you lengthen the tendon, this is called tendon lengthening. You release the contracture by soft tissue release. You transfer the tendons. For example, if the child is having fixed equinus contracture, you can go for tenotomy and TA lengthening, or you can transfer the tibialis posterior to dorsum to help the dorsiflexion. The joint capsule opening is called capsulotomies. Tenodesis, you cut the tendon and you stitch across the joint. Fasciectomies, gastrocnemius fascia is released. At times the fascia is contracted. Osteotomies, if the child is old and there are bony deformities, you go for bony osteotomies. Arthrodesis, if the joint is having a severe contracture, no muscles available, you correct and arthrodese the joint. Parent counseling is very important. Parents are the main shareholders. You must take into development of the and understanding of the family. They must understand the problem. So this is all about cerebral palsy. The take-home message is it is persistent but unchanging. Disorder of movement, tone, and posture due to a non-progressive defect or lesion of immature brain. This lesion had been exposed in mother's tummy, which is prenatal, while coming to this world, which is perinatal, or during infancy, first 3 years of life, when the brain of the child is very immature and is affected most of the time. Commonly associated disabilities can be mental retardation, visual, hearing, and sensory losses, strabismus, cognitive dysfunction, sensory problems, emotional and behavioral problems. This can be classified on the basis of the part of the brain involved, which is called topographic classification, in which either one limb monoplegia, one upper and lower limb hemiplegia, diplegia, paraplegia, double hemiplegia, triplegia, and pentaplegia can result. Physiologically, depending upon which system of the brain is involved. If the cerebral cortex is involved, this results in spastic cerebral palsy. If the pyramidal and extrapyramidal system is involved, this results in athetoid. Ataxic if cerebellum is involved. Mixed if it is different parts of the brain. Atonic if it is basal ganglia. So this is all about the cerebral palsy. There are cognitive problems, there are locomotive problems. The disability of the child should always be assessed on the different grading systems, whether the child is having a limitation, whether the child is able to be independent ambulator, dependent ambulator, wheelchair bound, or bed bound. These are the 4 grades. So you must be recognizing these classes, and then these are the different areas, different theories. In next lecture, we will go through the different surgical aspects of cerebral palsy. Then we will go to the poliomyelitis. We will help you then go to the myopathies, neuropathies, muscular dystrophies. So then there are different paralytic conditions. After that, our neuromuscular system will be gone. Then we will go for pediatric problems, congenital anomalies. Then we'll go for skeletal dysplasias, then locoregional disorders. And then I'll have a lecture, rehabilitation in arthroplasty patients. Any questions? You are welcome.
No, sir. Thank you.
You're welcome. So we'll have the next lecture by Friday, and that will be on the surgical aspects of cerebral palsy.
Okay, sir.
Have a good day.